So welcome everyone to the Peer Recovery Center of Excellence session on exploring Medicaid billing in recovery community organizations. We're going to spend the next hour with myself, Chris Kelly, and Wendy White-Tie Green. Next slide. Just a funding disclaimer that the views expressed here today do not necessarily reflect the official policies of the Department of Health and Human Services. Always, if we want addiction destigmatized, we need a language that's unified. So we never want to describe someone as their disease or diagnosis. We always want to use person-first language in all of our affairs. This is our pathway to technical assistance at the Peer Recovery Center of Excellence. So anyone can submit a request for technical assistance, which is really just support and resources. Someone from our center reaches out and connects you to a core team leader like myself. We discuss your request and then we provide you those resources, support, training, either from one of us on our Peer Recovery Center of Excellence team, or we bring in outside consultants as well. Just a reminder that today's session is being recorded and it will be posted to the Peer Recovery Center of Excellence website under our resources page. During the presentation, feel free to submit questions into the chat. I'll be monitoring the chat for Wendy, and we'll probably not respond to every single question as it comes up, because as you'll hear in the end of today's session, Wendy and I are going to host some office hours next week so that we can go into more detail with the questions we have. But at the end of today's and throughout, we'll try to address things as they come up as best as we can. Anyone interested, we will send out the PowerPoint for this presentation. And then also at the end of the session, we have a short evaluation for you to take. And I think this is where I hand it over to Wendy. Welcome, Wendy. Thank you for being here.
Oh, thanks so much, Chris. And I'm so delighted to get to spend some time with all of you, just knowing that y'all are championing recovery work in all of your communities. So great to be with you guys. So the agenda for the day, we're gonna, in order to kind of contemplate Medicaid billing in recovery community organizations and the potential for that, we're gonna just get a good foundation and some shared terminology to kick off our time together. And then we're going to think a little bit about like Medicaid dynamics and move a little bit more into detail, examining some of the primary Medicaid mechanisms that are available for billing behavioral health services, assess the landscape together, just to kind of what this might look like in each of your jurisdictions that you function in. You're all somehow in a state or a territory, and so you have to kind of assess that landscape. And then we'll talk a little bit about a tool that's going to be available through the Peer Recovery Center of Excellence just ahead that you can use for self-assessment. But first, we have some really exciting news that is particularly related to this conversation today, not directly, but very much adjacent and indirectly related. June 5th, so just earlier this month, the Federal Medicaid Agency released a new frequently asked questions document on peer support services. And when they do a frequently asked questions, it's just a little less formal than like one of their big memos that really function as policy. They can kind of write a little bit more flexibly about things. But after a lot of conversation from many leaders around the country, questioning supervision as it was defined in a 2007 memo that they had sent out, they have released some really awesome news. And that news specifically is allowing and clarifying that that Medicaid is acknowledging that they promote peer support. That's a reinforcing point. They open a couple of doors here in this introductory statement that I've highlighted that says that it includes allowing coverage of peer support services in emergency rooms, as well as in inpatient settings. Now, for any of you who might know Medicaid policy, that's tough to do, like the mechanics behind that, but it does open the door then for this conversation. And it also reinforces that payment rates should be sufficient. And that is going to factor into our conversation in a few slides ahead. So that's also a signal to state agencies that they need to be really mindful about the peer support reimbursement rate, which we're talking about Medicaid today. That is kind of a crux of how you might make a decision on whether or not to embrace Medicaid as a funding source. But above all of this, the major part of the frequently asked questions is about supervision. And historically, the memo in 2007 said language about that services had to be provided by a competent mental health professional. And so that mental health professional term made it a little tough over time for, well, how does substance abuse fit in this? And they did some clarifying memoranda about that helped that a little bit in 2018. But the term mental health professional in a lot of states is defined in code, like it's defined in like regulation or in law. And so it created a lot of challenges for states because they felt like, oh, if the memo says mental health professional and our definition of that in our state means independently licensed practitioner, then that's the same thing. Or we have to adopt it as the same thing. But the Medicaid agency has come in and said that the states have full authority to define this. And the second bullet is the most more important, which says that that individuals that are supervising peers can include individuals that are also unlicensed. And what that did then is to open the door for the third bullet, which says that peer specialists with a certain amount of experience and training as defined by the state can be recognized as the individual who will be doing the supervision. And so this is a super big win from a policy perspective for peers having a career ladder. So again, we're not going to dive into all of this today, but it makes a difference when you're starting to think about your local state's Medicaid rules and how you might want to advocate for that. And if you're an RCO and you're thinking about stepping into the Medicaid framework, but you don't have on your staff like an LCSW or a licensed professional counselor, and that's always kind of seemed awkward about kind of advancing them towards Medicaid. This gives a lot more flexibility. So everybody in the peer recovery space around the country is really excited by the memo. So had to touch on it today. It's so fresh, such breaking news. We wanted to share that. And then again, they recognize that there are already a couple of Medicaid state plans that already allow this and that those are available. And again, that states can propose their own plan as long as it kind of addresses the bullets at this bottom of the page. So anyway, great news. You'll have reference to it here if you haven't had a chance to see it yet, but it's very exciting from everybody's lens. Okay, so then the main part of our work today is we really want to think about Medicaid billing as a potential vehicle and mechanism for financial enhancement of recovery community organizations. And so jumping right into that, we know from around the country that there are a lot of different ways to fund RCOs, and not every RCO has all of these, and in fact, most RCOs probably only have one of these. But today we're going to focus on the three areas that have green stars, and they're all Medicaid. But we're going to kind of take those three and we're going to expand them and look at each one of those and begin to help you understand kind of what the elements are of those and how they may and could be used for potential pathway for funding for Medicaid reimbursement. Okay, so as I indicated, we got to get square on some terminology here. And Chris gave us kind of that person-centered, person-first language. But we got to get into some real technical kind of terms and get comfortable with using them here today. So peer support first. I think probably all of you know this term, but it's just, again, helpful, I think, from a grounding perspective to have a good definition of peer support. And the anchor of that, as you all know, I'm not going to read this stuff, but the anchor of that is that you have lived expertise in a mental health or substance use condition, and you have worked your steps towards some recovery with that. So whatever that was, whatever that personal journey was, you're experiencing some recovery, and you have been trained and most likely certified to use that lived expertise as a tool to help others find and achieve and maintain and sustain recovery. So pretty basic definitions. Peer support worker, all over the country, y'all, everybody's got a different term for this person. I'm using the phrasing today, peer support worker, because it is what SAMHSA has kind of recently adopted as kind of a standard and a norm, understanding that every state uses different titles, and they may even use different titles for mental health versus substance use versus parent versus youth, peer specialist or recovery coaches. There's just so many different terms. I've opted here today to go with peer support worker, since it's what SAMHSA is using very generalized right now. And those are the folks who are trained to do peer support and understand how to use that lived expertise as that tool to help others. So we're going to use that term kind of generally throughout the rest of our conversation today. Recovery community organizations. I'm not going to do any kind of deep dive on that. You guys are the experts at this. So again, you're going to see a couple of definitions here, but you all are the experts, facilitators and managers of these services locally. And then Medicaid. Of course, Medicaid is a state plus federal program. So you see two parts of this definition. And if you're not super familiar with Medicaid, I am going to just take a second here because that's going to be right at the core of our conversation. So at a federal level, the federal law from the 1960s established Medicaid, and it said that for individuals who have poverty and are experiencing, don't love the term, but it's in the federal law, disability, that based on certain qualifications, that they can get insurance that is co-paid by the state and the Medicaid agency federally together. So there's a ton of rules in federal Medicaid law and that come from the federal Medicaid agency that describe how certain mechanisms have to work through the federal agency. So there's some standardization around the country. And then once those kind of what I call like the bounds of the lanes are set up by the feds, then the states can do all kinds of stuff between those concrete barriers on the interstates here that the feds set up. So each state then decides and designs what services it can offer as long as it meets the minimum standards set forth by the federal government. And it can design and create and adopt and figure out the funding for all kinds of services. But they have to make an application to the federal government to say, do we have permission to do this? So that there's kind of a joint collaboration and agreement between. And then Medicaid will agree most often. And then it becomes a statewide benefit. So going state to state, Medicaid does not look the same. There's a fun phrase in Medicaid that says, if you've seen one Medicaid state agency, you've seen one Medicaid state agency, because every one of the plans is different, with a few exceptions. So there's certain things that are called mandatory benefits, and there's just a handful of them. But then pretty much everything else is just an optional pick list, which can include peer support and can include recovery community organization type services. Okay, so those are our main definitions. And so our questions for ourselves today, if you follow the definitions, like those headers, like at the top in the green boxes, and those were the definitions we talked about, but now follow the purple boxes across in a sentence form. Should an RCO delivering peer supports via a peer support worker pursue Medicaid funding for its mission? So that's really why we use these four big headers to define quickly together, because the questions, some of the questions that we're going to try to explore today, the question we're exploring is really what's in that purple box. So understanding these four definitions, like we can do a lot of advancing some learning about whether or not this is a good and viable option for some of you or not. Okay. To Medicaid or not to Medicaid? That is the question, right? It's an old quote from Shakespeare, and not to Medicaid, of course, the framework. So we know something that's really important to you without you telling us, y'all, which is sustainable funding allows the strategic continuation of the RCO mission. So in order to do what you love doing, what you are charged to do, what you are called to do, promoting community-based recovery for the folks you're serving, right? That's like generalist mission for all of you. You have to kind of think about, where am I going to get funds from? And so really, RCOs are a great place where recovery support's occurring, where staff are available, the peer support workers that offer that support, but space and staff require funding. And one of the most stable healthcare fund sources in the country is Medicaid. So this is a question you kind of just have to ask yourselves. When this concept was rolled out right in the mid-teens, no one really asked that question. They were like, oh, let's do some grants and roll this out. But no one really talked about sustainable funding for this model for the long haul. But you actually really, it seems ridiculous not to talk about Medicaid or consider Medicaid in that journey. And then the second big question I always ask, and people around the country, I'm a Medicaid funding and finance expert in behavioral health. So I've been doing this for, been doing mental health, public mental health work and addiction, substance use treatment work for like 35 years. But in the past 25 or so, it's all been about Medicaid. So I'm an expert, but I am not interested in medicating, I call it as a verb, medicating products that aren't really helpful to apply Medicaid to. So I try to be very fair and candid and honest about Medicaid sometimes can be a lot of requirements. So a question I always ask folks when I'm talking to them is the juice worth the squeeze? So when you're making lemonade, right, there's a little tiny bit of juice that comes out of that lemon. You have to work hard to get it out of that lemon just to get one glass of lemonade, right? And so Medicaid is really regulatory. It is complex. There's a lot of risk with it because of like audits and those parameters and accountabilities. And so as I talk with you today, I'm going to be talking to you with just a lot of transparency and candor about understanding, you each understanding how to think about Medicaid for your specific RCO, and then sometimes how you and your local neighbor RCOs might want to think about this together. So is the juice worth the squeeze? So Medicaid's super complex. Medicaid will require, no matter which pathway you choose towards it, it requires a substantial partnership with the state. And that may not be just the state Medicaid agency, but it may also be the behavioral health agency, which likely y'all have many deeper relationships with than with your Medicaid agency, just because of historic block grants and that type of funding. And it has tons of requisites and stipulations that an RCO has to assess. And we're going to talk about more of those in a future, but you have to, in a future slide, but you have to think about financial outlay. So again, before you might start making money, you might have to attest to a Medicaid agency that I have got A, B, C, and D things in place, which may mean that you're having to use any revenues or profit margins, thin as they may be, to be investing before you even get to the Medicaid table. So that outlay human resource capital, like how much will Medicaid documentation and the like change, like the number of hours that your staff has to do like documentation. That's one example. And then there's cultural sacrifice. So if you've had a super flexible model with very little parameters and rules around it, and then you want to make a choice about a program and a funding stream that has a ton of rules, that changes your culture. So you also have to think about those types of impacts to your organization. Again, it's not going to be a match for everybody, but I want you to lean in and listen, because I don't want money ever left on the table when it's really good money to grab. So we're going to explore it today, and many of you are going to go, yes, I can do that. And many of you are going to go, well, I'm about to spend an hour with Wendy, but I'm going to go embark on my weekend now and set that conversation aside. And then as Chris and I were talking about, in a lot of ways too, you can also just put some of this information in a file cabinet, and you can pull it out when you see a window of opportunity open. Okay, so juice worth the squeeze. Now you've got the Wendy lingo, not just the official terminology, but how Wendy talks about things. Okay, guys, so this is it. This is the crux of what we're talking about here today. There are 3 primary Medicaid funding models for behavioral health. There's some variations to all of these. There are special projects and pilots that federal Medicaid does. There's some local things that states can do a little differently. We'll talk about that. But these are the 3 big headers here, y'all. So Medicaid fee-for-service, which is basically how most healthcare is paid for. We go and we get a service, and somebody pays the practitioner for it, whether or not it's a cardiologist or an endocrinologist or a behavioral health peer support worker. So show up and get a service, and you get reimbursed for that widget. I'm going to call it a widget of service. There's Medicaid managed care. So some states say, like we want to kind of just put ourselves in an arm's length distance from this work. And so we're going to give it to a major company and let them manage it. And then there's a third type of Medicaid reimbursement for some services like this. It's called Medicaid administrative claiming. And that sounds kind of like it's not really clear what it could be, but we're going to talk a little bit about it. It's a thin opportunity for some behavioral health service reimbursement, but for non-traditional stuff, it's actually super helpful. So those are our big three we're going to hit on. So the first one, we're going to start with the most common, the most traditional form of reimbursement for services. And again, the second bullet here, is exactly what it says, fee for service. So basically, it's when a practitioner delivers a service, he or she submits a claim to Medicaid or to another payer. Like if you've got private insurance or exchange insurance, this happens like every time we go to the doctor, a claim is submitted for an intervention that was provided. And then that practitioner receives the reimbursement for that service. So you deliver a service, you get paid for a widget of service. Those services, though, have to be named, as I made a brief mention of earlier, in a Medicaid state plan. So the state Medicaid agency has to have like a roster of services and benefits that they have to name. And with the exception of like one state, like recovery community organization stuff is not really listed in Medicaid state plans around the country. Peer support is in most Medicaid state plans, though, by this time. And I will take one pause for a celebration to say that Medicaid first approved Georgia in July 1st, 1999 for peer support services. I was the broker and negotiator for that, which I always say then doesn't make me the smartest Medicaid expert, but it makes me the one doing the longest on Medicaid peer support because we established the very first service. But that also means that in a little less than 2 weeks, we celebrate the 25th anniversary of Medicaid reimbursed peer support for the country. So it's really pretty exciting times right now to be coming up on that giant benchmark. But what we did in Georgia was to get it listed in a Medicaid plan, and then everybody was like, "What? What did Georgia just do?" And they started copying, and that's awesome because it's like generated all of this major reimbursement and recognition that this is a legitimate service. When Medicaid recognizes a service, it's usually really a kind of a hard hill to climb, and so it gave it a lot of legitimacy and authority. And then states followed, and it's not just national now, it's international. So about between 20 and 30 other countries also have peer support. So getting something to a Medicaid state plan is a big deal. And but again, most, like all but one, states don't have anything like a recovery community organization listed. Medicaid does require, again, like the federal parameters are pretty, again, rigid. And most states say that you have to have a significant and detailed amount of billing documentation. That varies from states to states, but it's generally pretty rigorous. And the big part of that is that the person has to be medically needy, which again, person first language, but this is what the Medicaid language says. So you have to have a medical necessity determination. You have to be able to say, Wendy needs a particular type of service because she has a particular type of condition or need or an identified issue for which I need medical intervention. And then that usually then requires the widget documentation. So whether or not it's 15 minutes or hour widgets or a per diem, which means all day widget of service, You have to document that Wendy received that service on that day, and here's what she received, and here was her response to that, which then generally begets a need for an electronic health record. So you have a place to gather all of that in a real standard way for every time you have contact with Wendy in support of her. And then finally, the rate setting. And this is so crucial, everyone. But with like the original RCO grants that came from SAMHSA, there was kind of like a model nationally about how much money would go for an RCO or of a certain size and the like. And so they were kind of like big chunks of grant money. But with Medicaid, it has to be cost-based. So they want to survey providers on a regular basis to see how much cost is going into something. And then they put it into formula where it sets a rate. And for peer support, because salaries were so historically low for the early years of peer support, those salaries then being so low pulled the price tag down. So a lot of peer support services are reimbursed really low. And Georgia's always been in the top 5. And I still feel like that sometimes it's like offensive how low it is. And that's with us leading in the top 5 year over year with peer support rate setting. So it's really important if you're thinking about Medicaid, not just to examine all the things you need in-house, but again, is the juice worth the squeeze, right? Are you going to get enough juice out of that lemon to make a glass of lemonade? Okay, so what does this mean for you all? So every one of these that we're going to explore, there's 2 slides for like, what is the actual mechanism? And then what could this mean for you? And again, we can't do a deep dive in our short time today, but we're just giving you a little hint and a taste of what you would need to know here. So the first question you might want to ask yourself is, are there peer-delivered recovery supports that are already in a Medicaid state plan in your state? So if you understand what is already there, then you can think about bullet 2, which is what is the gap between what is defined there and what I do on a daily basis in my RCO. Because it may be that it's written broad enough and globally enough that you might get kind of come in and talk to a Medicaid agency about just changing a little thing or two and having a pathway for billing. Or you could be miles away from it. They might say you have to have, you must be open this number of hours and you must have this number of staff and you must have a doctor as a clinical director. Like there's all kinds of rules that each state can have. So what do you have already? Like what is already like on the grocer's shelf? And could it do in if you needed to do peer support, is it kind of a close enough thing that you want to take that box off the shelf and potentially use it? Tweak it just a little bit, or do you have to start from scratch? And then you have to then also think about your own agency and do some business assessment. So what are the program costs? What are the costs that you have every day and your current fund sources? So, and how many folks are you serving who actually have Medicaid? Many of you who are in expansion state, that answer may be tons. We can make so much money. If you were in a non-expansion state, you might just shake your head and walk away from this because you don't have even very many people with Medicaid coming to the program. And then you have to think about the rate. So that reimbursement rate we talked about, what is it? And if I, consider how much I might want to ultimately or could ultimately bill, like how much money would I draw in? And is it worth the cost? Juice worth the squeeze. So you have to kind of consider what are these pieces that are already in place? How far away might I be? And then what are those gaps? And then finally, you have to think about provider credentialing, because you may also look as you're doing this gap analysis of what Medicaid already has. And they may say that you have to have a certain type of national accreditation, or you have to have kind of a risk-based assets model where you have 6 months of assets to carry you in the event there was some delay in Medicaid billing. And on agencies that operate a thin margin, that may be tough. So you might want to look at the credentialing to see, is this too far away from me right now? And all of the answers to these questions for yourself, or again, even with a group of your neighboring RCOs, if you wanted to jointly approach a Medicaid agency, those things are good to understand and know in case you need to advocate to change it. So these two probably took the longest because I needed to lay some fundamentals. So the next two are going to go pretty fast. So Medicaid managed care. So again, sometimes the state decides to give the whole Medicaid list of services to an agency, a corporation who is going to administer a program. So in that case, they say to one or multiple managed care organizations, y'all take the list of our services and you go manage them. Usually when that happens, as through a contract, and the Medicaid agency sets what's called a per member per month reimbursement. So that managed care company may say, there's $100 for Wendy, and there's $100 for Chris, and there's $100 for Charity, and $100 for Misty. And they give all that money to the managed care company, and the managed care company just manages all the cost. So the goals of some of these programs are really to reduce program cost. A lot of people talk about promoting care coordination and quality. There's a lot of debate out there in the ether about does it accomplish that? But generally, these managed care companies pay the same way. They pay fee for service. So Acme Managed Care Company enters into a contract with an agency and they still pay fee for service. But they can do this thing at the bottom, which is super creative. The federal government allows them to do something called in lieu of services, which means basically managed care companies can do something creative and different to accomplish healthcare outcomes. RCOs may be the thing that can be an in lieu of service. So you wouldn't have to go fee for service. You could talk to the agency about becoming a contractor of theirs. So in this case, you would create, see the second bullet, a proposal for in lieu of services as an RCO. You would try to work with that MCO to broker an agreement or a contract with them to do your unique products. If you're going to create a proposal, you want to kind of know a little bit about, do they have any disparities that they're trying to work on, that managed care company, and that if they have one that's related to some substance use services, then that's again your sweet spot. They want a significant return on investment. They are mostly for profits. 95% of them are. So they want to pocket money for their shareholders. And so you have to show that you save money and you have to sell your product. That's basically what the third bullet is saying here. The one thing I want to just share though is a caution. If you go into this space, you have to very carefully and prudently, soundly, with legal counsel, I suggest, enter into agreements with the MCOs, because there could be penalties and clawbacks audits which come after money. So you just want to be very careful as you're entering into the agreements that you and your agency are protected. And then finally, administrative claiming. This is a law, and it's actually, again, super flexible. It says that for Medicaid, you can do extra stuff that's necessary for the proper administration of the state plan. So it's stuff along the side of all that list of services, and states can actually pay or reimburse for these unique things. So you may be the unique thing that the Medicaid agency is looking for. In this case, the RCO has to work with the state. The state has to make a proposal then to federal Medicaid, which means you feeding a lot of proposal information to the state Medicaid agency. So it's administratively complex at the front. You have to pull a lot of stuff together, your proposals, what it looks like. Are you going to do this like statewide, which most Medicaid agencies want you to do? So you have to work really hard on a proposal and really hard on building a relationship with the Medicaid agency to kind of get their time and energy to sit down with you and create this together. But generally that's like a 50-50 matching amount of money, which means that if you have, if you're serving for your business about $100,000 a month worth of Medicaid service delivery, and you have $50,000 in your budget, you can draw down $50,000 to match that money. And so it becomes a 50-50 matching rate. This just requires a lot of partnership and a lot of collaboration out the front. And so I underline here, then convincing your state Medicaid agency that you are crucial to folks with substance use getting the supports they need and the recovery they need for the long run. And just don't kid yourself, even though it's like easy for the long haul to do like a monthly report, progress report to get your administrative money through the Medicaid agency. They're still going to ask for a ton of accountability data. They may still ask for stuff like electronic health records, and they may still have some parameters they build into the contract. Okay, so a couple of closing thoughts. Assessing the landscape is just critical. So you have to think about the risks and the benefits here. So like this financial capital, human capital, infrastructure investment on the risks. The benefits, of course, are the revenues and the reimbursement, and then you're integrated into a Medicaid network where a lot of other entities are supporting individuals who are Medicaid beneficiaries. So you're part of a healthcare network, which again strengthens your long-range sustainability in the healthcare industry. Every one of you, this is going to be different for. So you've got different expertise on your staff. You've got different board expertise, people who are sitting on your board of directors. You have different CEOs or CFOs or chief administrators. So based on their experience, this may seem easy, or this may seem like it's a foreign language. So you have to kind of assess for some of that. And then also, again, your recovery culture. And I mentioned this at the beginning, so I just can't say it enough. If your culture right now is super flexible, you don't ask for people's insurance cards, you don't always note when Wendy's there, like if it's Monday through Friday, but it's a drop-in kind of function. If I have to start signing in and do time in, time out, how does that change things for my culture? So just, I encourage you, just as a recovery champion, just keep your vision and mission kind of at the heart and the core of everything you're thinking about, and you'll make the wise business decisions. So finally, just we wanted to show you what's going to be available in the near future from the Center of Excellence. And we've just created a list of self-assessment questions. It's a whole tool and framework for folks to look at themselves and their state culture, both, to determine these things together and get them documented. So part one of the assessment is really what is in the state ecosphere there, and just recognizing that and getting that documented. And then sorry, I flipped those. And then what are your how does your behavioral health agency and your particular entity actually measure up in your readiness for this? So this is a tool that's going to be made available to you guys right around the corner. Okay, so we're at the point for questions, y'all.
Thank you, Wendy. I know we had one from Natalie of where do you recommend that we go to learn about what we need for Medicaid in our state? I did drop in the chat a little bit earlier. The Peer Center of Excellence did a kind of a resource guide compendium on state by state. Does your state already have peer support services in its Medicaid, state Medicaid plan? And so the link I just put into the chat is a state by state breakdown, and that's also available as a resource on our website, the Peer Recovery Center of Excellence website. And because Minnesota, we did this, and actually recovery community, I live in St. Paul, Minnesota. Recovery community organizations are vendors of Medicaid vendors of peer support services in our state. And from experience, what I would say is first start talking to your other RCOs in the state. Like, get everybody together and get different feelings on this topic, because if it moves forward, you're going to want to have a strong, aligned network of RCOs going to your state Medicaid plans and your behavioral health divisions with a kind of a combined ask versus trying to do it as a single RCO. But I'm going to let Wendy reflect on that as well.
I will also say the state Medicaid agencies, every time they do a state plan amendment, it's a public notice. So they generally have a running list of their public notices of what's been approved in their state. So those are generally on the state Medicaid agency website. And CMS actually has a portal for every Medicaid state plan in the country. So I think if you go to the compendium that Chris was recommending, which is just a great tool, and you see that your state has it, if you want to get more detail, you can either go on that state's, your own state's Medicaid website and access like a provider manual or something of that nature, or you can go straight to the horse's mouth at federal CMS and look up state plans. And you can search by state or by year. Like if you think, oh, I think they did something in 2019, you can type in your state and the year and even keywords like peer, and you can find some of that information that way as well. So I see the question from Robert. So I'll read it out loud for folks if you're not looking. So any insight you may be able to offer on that new guidance that we went over in the first 3 slides. But he's saying that the state Medicaid agency agrees it allows for peers to be supervised, but has also asked for guidance that peer supervisors can establish medical necessity in the same as an MHP, mental health professional, could do in reference to the peer service. So, well, Robert, let me just tell you, if I was writing tabula rasa, I would just remind them that this isn't a clinical service, it's a recovery service, and that peers who've practiced for a while recognize what is medical necessity for recovery. And we're not asking them to, be diagnosticians, but we are asking folks to be able to articulate that there are certain recovery needs of that person and be able to justify them. I will also remind folks, and again, Robert's kind of, it sounds like he's kind of skilled at this, but Medicaid will also allow a separate order, like an order for services, and that can be done also by somebody else. It doesn't have to be the same agency that is doing some of these services. So if your Medicaid agency is really a stickler on things like this establishing medical necessity, you could strike referral agreements with other agencies who provide like a diagnosis. But then you just document what the recovery needs are. But sometimes a Medicaid agency can be just appeased by being sure that you're able to gather from somewhere else, a PCP or another mental health center or addiction center, substance use support treatment facility, where you could get a diagnosis, which may that's been verified like in the past year to 2 years, that would justify also some clinical medical necessity without you all having to get into those weeds. And that's real state specific too. Like I said, it's kind of depends on what kind of sticklers your your state Medicaid agency is. Okay, so Phillips. I'm not sure if you're going to say Phillips or Phillips Chase. I see this one, and this one is a great one. Good question. And I will just share that the National Association of State Mental Health Program Directors, NASHPID, has a great paper on this. But what we had to do in Georgia, and we're highlighted in that paper, is we had to go to the Medicaid agency and sit down and talk about some rule outs. So like for the children's peer support services, like we can't have these felonies, but we've brokered that the adult stuff can. And there are exemption processes and policies that we had to put into place for this. So initially you may get a denial on your background check for working in a Medicaid program, but then we have an extensive board that does individualized review of these, and our Medicaid agency let us have that exemption with that kind of board review process sitting at a state level agency. So it's not at the agency level that kind of overturn could happen. It's actually at the state certifying body. And that we brokered that with our sister agency. Let's see. I am looking.
I think we're covering a lot of them, a lot of the questions. I think, as Wendy said, there is so much more to come on this topic from the Peer Recovery Center of Excellence. One of the things Wendy and I are going to do is, do you want to bump to that slide, Wendy? Next Friday, the 28th, we will be hosting some open office hours where Wendy, myself, and then a person who leads Marco, so the Minnesota Alliance of Recovery Community Organizations, will just have office hours where we can get into the weeds with some of the questions. I will be sending this out in a follow-up email that'll include the PowerPoints, and then you'll get this Zoom link if you want to join us next Friday. And then there'll be a written document covering everything we talked about today as well. That'll give you links to some of these, to how do you find some of this information and start going down some of those rabbit holes. And then also keep looking at the Peer Recovery Center of Excellence site, because we have so much information gathered over the most recent years around state certifications, which states allow for peer support Medicaid billing. Is it substance use disorder? Is it family support? Is it mental health? Is it integrated? What are the rates per state? A lot of that information is already there. So I'll compile those links within this email so you kind of have it at your fingertips. And then I think Phillips asked, could I please get some info on who to contact for what you mentioned? And so it'll all come out in an email, Phillips. And I say anyone interested in kind of digging deeper, join us next Friday. You can always submit a request to the Peer Recovery Center of Excellence as well, a request for technical assistance, and you can do that through our main webpage. And we'd reach back out to you and do some one-to-one work. I will say, I will direct RCOs to bring others into the process with them. So it's really hard if you're a single RCO trying to do this work. I would work with you to identify other RCOs in your state and see if we can't bring them to the table to have a fuller discussion so that we can really think through, is this something we really want? Is it going to benefit us? Is the juice worth the squeeze? If your reimbursement rates in your state don't cover the costs of providing the support, I would say let's start at how do we get those reimbursement rates increased? So you don't, there's different starting places for everyone on this journey. And I say this with my lived experience of doing this in the state of Minnesota. There's lots I know now that I wish I knew then. A lot of things to get in statute, a lot of policy to firm up, a lot of sometimes loopholes you want to look at, but it's not impossible, and it certainly has been beneficial to a number of RCOs in our state to add to braided funding streams. And the last little thing I'm going to ask you for is if you'll complete an evaluation at the end of today's session. The evaluation link is in the chat. And what that does, it allows us to let SAMHSA know if you enjoy events like this. You can also take a picture of that, bring up your phone and do the QR code on your phone if you want to take that short evaluation. But this information goes directly to SAMHSA to let them know that this information is useful and helpful to the work you're doing, and hopefully advocates that we keep opportunities like this funded in the future. So we're at 1:59. Well done, Wendy. I just want to thank you. I hope all of you see the magic of Wendy understanding this intersection between Medicaid and RCOs. You will receive an email, probably not today yet, because I want to get some things together so that I have a fuller email with all those links we talked about. The guide will be coming out in a week or so, as well as a recording so you can re-watch this. So thank you to everyone. Thank you to Wendy. Appreciate you all.
Absolutely. And Chris, I'll send that Nashville